Good afternoon. My name is Alan Sager, and the question we're addressing today is, why should we care about urban hospital closings? To leave time for any questions you might have, I'm going to stick fairly closely to the slides, and also in the interest of time, the jokes have to go. So let's begin. We'll be taking up four main ideas today. First, an overview of the problem. Second, which hospitals close. Third, why do closings matter? And fourth, how to stabilize needed hospitals if we decide we'd like to do that. By way of overview, the care we get, the health care we get, depends heavily on the caregivers we've got. The configuration of urban hospital care, its shape, the location of hospitals, their sizes, types of hospitals, teaching, non-teaching, and the number of beds. The shape of hospital care evolves constantly. Smaller and mid-sized hospitals and those in African American neighborhoods have been much likelier to close. But hospital efficiency, cost per discharge, confers no survival advantage. Closings mean impaired access and higher cost. Quality, there are mixed effects. As a result of the closings, large areas of cities have become hospital deserts. The policy of closing hospitals to save money is a 4-decade failure. Financial, legal, and political tools are needed to identify and stabilize the hospitals and emergency rooms we need to protect our health. More specifically, in 1946, Congress passed a law called Hill-Burton that aimed to achieve 4.5 acute hospital beds per 1,000 Americans. Just as we approached that goal 30 years later, during the 1970s, a combination of two oil shocks meant stagflation, low economic growth, high unemployment, and high inflation. At that time, just 10 years after the passage of Medicare and Medicaid, rising health care costs plus stagflation meant great worry about health care costs. Some people looked around and said, politically, hospitals are where costly care happens, so let's find ways to cut the number of beds. Fewer beds, lower costs, some people thought. And they sought the greatest savings by closing entire hospitals. At first, to close hospitals, there was some reliance on public planning in some states, but that proved slow, partly because opponents of a given closing had time to mobilize and raise arguments in opposition. As a result, more and more pressure in some states grew to, they used the word unleash, market forces, competition, whatever that meant, on hospitals, maybe underpay them systematically. And that did accelerate the pace of closings dramatically. Hospitals closed quickly, but costs of health care did not fall. Part of what was going on was perception that we had too many hospital beds, so we should close hospitals. This rested partly on a belief that empty beds were costly. That's a big question, because once you build the beds, it's a sunk cost or a fixed cost. Doesn't change. The idea of moving care out of hospitals rested partly on improved technology, better anesthesia, better imaging, improved surgical techniques, laparoscopic surgery. Also, construction of ambulatory surgery centers in some suburbs, construction of freestanding emergency rooms, earlier discharge of patients from hospitals to nursing homes and home health care. This rested partly on an assertion that hospitals can be dangerous places, and that's sometimes true. Hospital-acquired infections are a real problem. Also, there was a belief that, well, maybe we don't need hospitals so much. Maybe prevention is more important than treatment. On the other hand, hospitals can be valuable. They can be needed havens in time of natural or human-caused disasters. They can guarantee access to care because they have addresses. People know where they are, and people who come with health problems have a much greater chance of being served. Hospitals are also important, not just in themselves, but as a vital foundation of doctor care. Hospitals don't substitute for doctors. Doctors don't substitute for hospitals. We need them both. The alternatives to hospitals, like ambulatory surgery and urgent care, are typically built in wealthier areas, not the areas where hospitals close. Some payers try to move their care from the emergency room or from the hospital to dodge paying their fair share of the fixed cost of the hospital and stick other payers with those costs. Some people argue that moving care from the hospital to ambulatory surgery center saves money. But if patients need the care, and if they get essentially the same services in both sites, needed services, how does moving the patient from one place to another save money? Now, without a functioning free market or competent government, how do we know that any existing or changed types of care are good or bad? And that's part of the general policy context we have to think about here, I believe. The competitive free market fails almost everywhere in healthcare. Not one of the 6 conditions for genuine free market competition are satisfied, or I think can be satisfied, in healthcare. At the same time, government in healthcare fails to protect access, contain cost, safeguard quality, or advance, protect an appropriate configuration of hospitals or doctors. Without a competent market or competent government, the result is anarchy, chaos. Let's look at behind the speculation about whether hospitals are needed to examine practical causes and effects of closings. I've tracked 1,200 hospitals in 52 cities over 75 years. Those are the locations of the hospitals, and those pretty much match the population density in the country. Looking not over space, over geography, but over time now, in the 52 cities, we started with about 717 hospitals in 1936. That went up almost to 800 by 1970, but has dropped to 426 in 2010 and below 400 hospitals today. Looking at beds per 1,000 people, the lighter, taller bars are beds per 1,000 citizens of the 52 cities, and the darker bars are the national figures. They rose in the 52 cities and nationally, and fell. By 2010, though, we had fewer than one bed. We had one bed per 1,000 people less in 2010 than we started with in 1940. So hospital capacity is markedly reduced. Looking at hospitals now by their teaching status or medical school affiliation, we see that the black and the gray, the major and minor teaching hospitals respectively, are a smaller share of hospitals in 1950, but a much bigger share in 2010. That's even more clear here, where we see beds by teaching status as a percentage of the total. And we see that the community hospitals, represented in that tan with the dead fish fossils, in 1950 are more than half the beds, but the community hospitals have fewer than a quarter of the beds in 2010. This chart summarizes changes over time, and we see that the closings in the third column of data, the percent of closings, 11%, 11%, 12% in the first 3 periods, give rise to 20% of hospitals closing, just about, in the successive 4 decades. So a rapid acceleration in closings. Let's look at which hospitals close. First, we know that there's a lot of variation in healthcare financing. If we look at hospital profitability for entire states, we see enormous differences with Hawaii hospitals showing negative financial margins, and Utah hospitals on the far right, the most profitable in the country year after year. Within states, we see even greater dispersal, greater variation in hospital profitability. These are data from Massachusetts showing a lot of hospitals losing a lot of money and a lot of hospitals making a lot of money. Now, are rich and poor hospital, the differences among those hospitals, are they justified? Rich hospitals, what are they like? They have lots of privately insured patients, tend to be located in higher income areas. They treat more profitable diagnoses. They have lots of doctors. And especially if they're teaching hospitals, they have lots of doctors on salary to admit and care for patients. Are they more efficient? Do their profits come from greater efficiency? No. They do have higher financial endowments, accumulated wealth from profits of the past and from gifts. Their reputation may be stronger. They can more easily attract patients from a distance. They certainly have more political power, partly because they're bigger, and partly because they're the places where political figures, governors, senators, and corporate executives are more likely to seek care. Are there high profits a fair reward by a functioning real free market? I don't think so. Poor hospitals, what are they like? They have lots of Medicaid and uninsured patients. They're located much more likely in African American neighborhoods, more unprofitable diagnoses, rely heavily on doctors in private practice who are often vanishing from large expanses of cities. And they have other problems as well. Now, this chart's a little complicated, but it's really important. That's why I'll show it again later. The blue shows for each of the three hospitals, non-teaching community hospitals, minor teaching and major teaching, the cost per admission for hospitals that closed between 1980 and 2010. The red shows cost per admission for the comparable hospitals that stayed open. And we see that within each group, the lower cost hospitals, lower case mix adjusted cost per discharge, meaning the more efficient hospitals, are actually slightly more likely to close decade by decade, and certainly over the 30 years. One finding that's especially striking here is that the right-hand column in red, the one with the circle near the top, those are the surviving major teaching hospitals. They were in 1980 48% more costly, controlling for case mix, for severity of illness, than the hospitals in the far left-hand column, the community hospitals that closed during the 3 decades. So in 1980, the major teaching hospitals that survived were almost 50% more costly, less efficient than the community hospitals that closed. Here we see a comparison of the hospitals that closed, this time in red, and those that survived in blue, by the racial mix of the neighborhood surrounding the hospital. And in almost every decade, there's a vast difference showing that hospitals in African American neighborhoods are much more likely to close. And this is true by decade, over 20 years, over 30 years. Very durable pattern. What's that? Ebbets Field, where the Brooklyn Dodgers played until they moved to Los Angeles in 1957. Turns out, a lot of Major League Baseball teams moved to another city or within a city in the 1950s and 1960s. The only factor that begins to explain that, to predict that, is the racial mix of the people living around the stadium. Not attendance of the team, not place in the standings or age of the stadium. Those bottom 3 measures might help manifest the finances of the team. But it turns out that the racial mix is the only factor that has any predictive value. And we'll come back to that. Here we see a summary from a logistic regression of the predicted chance of a hospital, an average hospital, closing during the 2 decades from 1990 to 2010, in light of the hospitals and the neighborhoods' 1990 characteristics. The number in the lower right-hand corner in red shows the predicted chance of closing, 26%, for the average hospital, based on the average values of the hospitals. Now, what we can try to do here is back out of this and look at this instead in Excel. And to do that, so just take a second if we're lucky. It turns out if we, again, please look at the 26% in red in the lower right-hand corner. If we change the number of beds in the hospital from the mean value of 328 down to 220, which we can do, we see that the average chance of closing rises to 39% from 26%. If at the same time we change the area percent black around the hospital from the mean value of 28%, 29%, up to 80%, we see that the predicted chance of closing increases. Whoops, that's because we have an extra, can't go over 100%. If we change it to 80%, we see that the predicted chance of closing rises from 39% to 51%. So that's pretty dramatic. Back to our slideshow. Okay. This slide summarizes the characteristics of the chance of closing of hospitals with different characteristics. We see that a 600-bed hospital in a 5% black neighborhood has a 6.1% chance of closing. We see that a 600-bed hospital in a 5% black neighborhood, thank you, has a 6.1% chance of closing. But a 176-bed hospital in a 99% black neighborhood has 10 times the chance of closing, 63%, a dramatic difference. Well, in light of these predictions about which hospitals close and which ones survive, and recognizing that race matters, hospital size matters, being a teaching hospital matters, wealth matters, but efficiency has almost no predictive value. Why do hospital closings matter for access, cost, and quality? Well, we could ask, so what? Don't some hospitals close because patients leave? They just vote with their feet. Are they just avoiding low quality or unresponsive hospitals? We could ask if a hospital is really needed, if it's losing money. Do we really need hospitals? Wouldn't more community health centers be an adequate substitute? To help address these questions, let's first remind ourselves that in the United States, no one has the job of assuring access to care or containing cost of care. Second, let's look at the evidence on hospital closings' effects on access and cost and quality. Let's start with ambulatory care. In the United States, on the left-hand side for whites, about 1/6 of visits by whites to doctors in a typical year are made in a hospital, to an emergency room in yellow or to a hospital outpatient clinic in blue. But for African Americans, the comparable figures are 1/3 of all visits by African Americans to doctors are in hospital emergency rooms or hospital outpatient clinics. So The effect of a hospital closing on African Americans, on average, will be double that, double the effect on whites in access to doctor services. Especially, this is an important problem because hospital closings disproportionately displace ambulatory care for blacks, partly because African Americans rely more heavily on the hospital for doctor visits, and partly because hospital closings are so heavily concentrated in African American neighborhoods. The loss of a hospital further undermines the remaining doctors in private practice in the neighborhood around the hospital. Community health centers are not adequate substitutes for a closed hospital, especially in arranging specialty physician care. It's also worth looking at other countries like the UK and Canada that guarantee and have for decades guaranteed health care for all, financial coverage for everyone. Even there, in cities, minority and low-income citizens are much more likely to rely on the hospital emergency room because they're much less likely to have a doctor in primary care. I think hospitals and doctors are symbiotic, not substitutes. Need both. If a neighborhood changes, ordinary non-teaching hospitals, community hospitals, remain behind. They often want to continue, typically want to continue to provide care to the new residents. But if doctors in private practice, who are the doctors who admit and care for patients at the hospital, follow their patients to the suburb because doctors tend to serve people in their practice, in private practice, not places. If the doctors follow their patients to a suburb, the hospital that remains behind, wanting to serve the new residents who overwhelmingly have health insurance. The hospital is like a car with a well-tuned motor and new tires, but it doesn't have a transmission. It lacks the doctors to admit, care for patients, and generate revenue for the hospital. It's simply much easier for doctors to relocate than it is for hospitals. Further, again, the loss of the hospital undercuts the practices of the remaining doctors who'd like to continue practicing in the neighborhood. On the inpatient side as well, the cumulative loss of access grows over time as large expanses of many U.S. cities lose all their hospitals, becoming medical wastelands or medical deserts. Almost half of all hospitals open in 1970 had closed by 2010. 3/5 of the hospitals in areas more than 60% black closed during that period also. Separately, it's simply wrong to put too many beds in too few baskets. Think about what happened in New Orleans after Hurricane Katrina or in New York City after Hurricane Sandy. In Manhattan, for example, below Central Park, only one emergency room remained open for a borough with more than 1.5 million residents. In other cities, we see enormous changes over time. In St. Louis, for example, there are no hospitals left in the northern half of the city, the African American half. And there are similar problems in the adjacent suburbs, north and west of the city. Sportsman's Park in St. Louis, northern half of the city, gone. Also, many of very substantial hospitals, including 3 public hospitals in the northern half of the city. Those are some of them. Detroit, even more dramatically. Detroit has lost half its people, but more than 90% of its hospitals. We have a city that's 3 times as big as Boston in geography, over 130 square miles. 4 hospitals remain open, all of them expensive, major teaching hospitals. And that's to serve a city 3 times as big as Boston, where the side streets are simply not plowed after snowstorms, making it hard for ambulances to get through. A couple of the hospitals that closed in Detroit. Washington, D.C., no hospitals left in the eastern half of the city except one propped up with city funds. Again, after many hospitals closed, including the only public hospital at the time. We see this also in this chart where blue dots are African Americans, red dots are Caucasian Americans. Overwhelming patterns of hospital closings, large deserts, not replaced by adequate primary care. Ironically, the first major league team to leave Washington for Minneapolis is now the site of Howard University Hospital, which had been across the street previously. And some of the hospitals that closed in Washington, some many years ago, some just this year. Now, access is a problem in the wake of hospital closings. So is cost, especially for people who imagine that free market competition is possible. Fewer hospitals mean fewer competitors every year. That means less price competition. That means higher prices. That means higher revenue for surviving hospitals, allowing them to incur still higher costs. And that's before surviving hospitals merge to gain even more leverage and higher prices over payers. There's a slight to moderate tendency in each decade for the more efficient, less costly hospitals to close, and teaching hospitals' growing share of most cities' hospital beds, up from 44% in 1970 to 77% in 2010 and higher today, means a radical change in the shape of urban hospital care. Again, we see the surviving major teaching hospitals 48% more costly in 1980 than the community hospitals that closed during the decade from 1980 to 2010. Over 15 cities rely on major teaching hospitals for more than 70% of their hospital beds and a greater share of their care. If our lower income urban patients get care, that care is increasingly given in the world's most expensive teaching hospitals. That boosts the cost of Medicaid. It's hard also for these major teaching hospitals to give care cheaply, even for uncomplicated problems. A combination of the closing of more efficient hospitals in the community hospital, minor teaching and major teaching categories, and especially the shift of patients toward major teaching hospitals, owing to the closing of community hospitals, the expansion of teaching hospitals, and the conversion of some hospitals to major teaching hospitals, boosted 2010 hospital costs in the 52 cities by about 20%, higher than it would have been had the 1980 shape of hospital care persisted. That's a $12 billion increase for just 1 year. We have a cost paradox. Surviving major teaching hospitals are increasingly essential to protecting access for urban patients, but also increasingly unaffordable for payers. Almost all major teaching hospitals have survived until now. Few alternatives remain open in many cities. They often merge to gain even greater leverage over payers. They have strong political backing. But will they have to change to survive? Will they feel pressure to change? Will they be willing to change or able to change in order to survive, to make health care affordable for all of us in the years ahead? This chart is a little complicated, but it shows one aspect of the failure of 4 decades of efforts to close hospitals. The blue bars are hospital beds per 1,000 people in the United States every 5 years, going up and going down. The dark red line is hospital cost per American, controlling for inflation. As the number of beds per 1,000 goes up in the left-hand side of the chart, hospital cost per person rises. As the number of beds per 1,000 goes down in the right-hand side of the chart, after 1975 or so, hospital cost per person rises even faster. So we add beds, costs rise. We close beds, hospital costs rise faster. Quality. Well, many of the closed hospitals were effectively racially segregated and low in quality. If so, the closing of heavily black non-teaching hospitals and relocation of their patients to large teaching hospitals might mean more integrated mainstream care, boosting quality for patients. And that's true in many cases. In some cases, though, There are questions about whether patients with routine problems get good care in teaching hospitals that focus more on more complex problems. Another question that arises sometimes is whether care at racially integrated teaching hospitals is itself racially neutral. On balance, there are probably positive effects of hospital closings for quality. But the alternative of upgrading quality at all hospitals has probably gotten much less attention than it deserves. And that's important because at any time, half of all hospitals' quality is below the median, and that shouldn't surprise any of us. It's not acceptable. Something has to be done. Hospital closings may constitute the longest-running policy failure in U.S. healthcare. Who sustains it? Who benefits? People unserious about containing cost, those unwilling to disturb prestigious and costly teaching hospitals, unwilling to disturb more money for business as usual at those hospitals, those untroubled by the visible gap in closings by race, and those who imagine a competent free market justly chooses winners and losers. People not serious about cost control, maybe most Americans. Political support for containing healthcare cost is simply weak, but politicians and others have to look busy, so they close hospitals. Some say, well, primary care is all you need, or greater attention to social determinants of health. Prevention is what really matters. I don't think we'll live forever, even if we prevent. Besides, focusing on social determinants excessively lets health care and hospitals off the hook. And that's important because prevention always fails. Why are we spending $3.7 trillion on health care in the United States this year? 5 times defense, $10 billion a day, $10,000 per American. I think we're spending that money to win medical security, which is confidence that when any of us becomes ill or injured or disabled, we get care that's competent, appropriate and effective, kind, coordinated, continuous, and quick, without worrying about the bill or fearing bankruptcy or thinking we'd better not try for care next time because we owe too much and someone will garnish our wages or put a lien on our house. Medical security is a vital aim, and we're far from it in this country. It might help to stabilize needed hospitals. The case for intervention has several parts. We don't have a functioning free market to weed out the inefficient ones. Even if we had a free market, it could only ratify purchasing power and doctor location, both of which are very maldistributed today. The racial link with closings is very troubling. Bed shortages may loom in many areas. Not too long ago, the Canadian province of Alberta found it might be short 3,000 beds. That's consequential. The cost of replacing closed beds has surpassed $1 million per bed in many places and has approached $2 and even $3 million per bed in some cases. So adding 1,000 beds, $1 billion or $2 billion or $3 billion to replace beds that exist today. Keeping a hospital open in an underserved area, having that reality is worth more than promises of some alternative tomorrow. Something real today is worth more than a vague promise for tomorrow that very often doesn't materialize, like better primary care. Hospital can be important, especially when its survival can depend on organizing primary care and emergency room care for people who live nearby. Ambulatory surgery centers, urgent care centers, freestanding emergency rooms, and other alternatives to hospitals typically locate in wealthier areas and wider areas than the neighborhoods whose hospitals close. With so many hospitals closed decade after decade, and given the types of hospitals that close and the causes of closing, the burden of proof has to shift. No hospital should be allowed to close without proof it is no longer needed to protect the health of the public. the shape of hospital care matters. Having the right types of hospitals in the right place and the right numbers of hospitals is vital to protecting the health of Americans. We could take a few action steps. First, identify needed hospitals that are likely to close. Which hospitals and emergency rooms are essential to protect the health of the public, and also to attract doctors to each locality. What types of hospitals located where are needed? Only one state even has such a list. 49 don't. Once we know which hospitals are needed, the next step is to identify which of the needed hospitals is at high risk of closing. We can track hospital finances from year to year and have a good idea of which hospitals might close next year. But we need a model to identify and predict with accuracy 5 or 10 years ahead which hospitals are likely to close. We can do that. Second action step, raise public awareness of the risk to needed hospitals. And that's hard because trustees and managers of vulnerable hospitals often deny problems until it's too late to do anything about them. They claim that going public would undermine the hospital prematurely by calling attention to its financial difficulties. They often act, though, as if they thought, if we can't save this hospital, we'd be embarrassed if somebody else bailed us out. They often believe that hospitals that can't compete in the market deserve to close. They blame the victim, they blame themselves, often refusing to recognize that forces outside their control may be destabilizing a hospital, that the playing field, if you want to call it that, is far from level. Third action step. For temporary protection, each state should enact a hospital receivership law, allowing officials or citizens to petition a court to take control of a hospital and stabilize its finances. Associated with that, governors or public health commissioners should be empowered and motivated to declare that closing a vulnerable but needed hospital constitutes a public health emergency that warrants seizing control of a hospital temporarily to stabilize it. Both of those two legal steps, receivership or declaring a public health emergency, needs to rest on adequate financing. And having an insurance fund for hospitals, different kind of hospital insurance, financed by a 0.25% assessment on each hospital's revenue yearly, would generate about $2 billion a year, which goes very far in stabilizing needed hospitals, many of which are closing, even though they're not losing a lot of money, partly because they're small, or partly because they simply don't have a huge negative financial margin. A little money can go a long way. It's worth noting that the Federal Housing Administration and Veterans Administration financed the construction of more than 50 million homes in the United States in the years since the Second World War by a 0.25% insurance premium. So that number is not without useful precedent. Also, instead of closing hospitals, we might consider mothballing them. We're keeping them under license, so if needed, they could be reopened. A fourth action step, to durably protect each needed hospital, each state could establish hospital rate setting, all-payer rate setting, to guarantee enough money to sustain efficient, high-quality operation at each needed hospital. That would mean each payer paying the same price, not private insurance paying more than Medicare or Medicare paying more than Medicaid, tilting the finances unfairly toward hospitals that rely heavily on Medicare and Medicaid, how things are today. Instead, all payers pay the same price. And all hospitals that are needed are allowed to generate enough revenue to cover the cost of efficient provision of needed care. In a free market, all payers would pay the same price, if we had one, a free market. Ironically, only public regulatory structures can give us the single price for paying for hospital care that a free market would provide if we had one. one price regardless of teaching status, protecting each needed hospital, regardless of teaching status, wealth, neighborhood demographics, and the like. The fifth action step is to confront low-quality hospitals of any type, any service, and demand substantial improvements in quality. Closing hospitals may move the problem, may provide some increases in quality, but far better, I think, to stabilize quality and boost it wherever quality problems exist, rather than potentially moving the quality problem to other locations. Protecting access and holding down cost of care. So I think those are some of the reasons we should be concerned about the pattern of hospital closings. Thanks for watching, and I think we have time now for some questions. One question is, what can smaller hospitals with less profitable patient pools do to sustain themselves? Are they eligible to receive disproportionate share hospital payments to subsidize them? They are, but disproportionate share hospital payments in state Medicaid programs, which is where the bulk of the disproportionate share money has come from, until the ACA, that money was provided with almost no link to which hospitals were vulnerable or which hospitals really needed the money. States gave out the money in very politicized ways in most states. A second issue with DSH, or disproportionate share hospital money, is that the ACA cut it radically, partly because the ACA aimed to expand coverage to 2/3 of 50 million uninsured Americans. Unfortunately, owing to many states' failure to expand Medicaid and other things that have happened, especially since the last election, only 20 million people have been covered by ACA expansions, not the 33, 35 million who'd been expected. So disproportionate share money has been cut, but the offsetting expansions in coverage haven't been realized. However, targeted money to protect needed hospitals, whether it's through a disproportionate share hospital program or other programs like the 0.25% revolving loan fund and revolving grant fund I described a few minutes ago, would be very good ideas. Another question. How does the notion of urban hospitals being more likely to close apply in a place like Boston, where there's great variability of socioeconomic status and race between blocks? Well, that's true in a number of cities. What we did was to look heavily at at large areas around each hospital. These large areas around each hospital were the census tract containing the hospital and all contiguous tracts whose outer boundaries were about equidistant from the hospital. And these areas averaged between 35 and 50,000 people. So we didn't look so much at the blocks containing the hospital or the blocks touching the hospital, but substantially larger areas that describe the neighborhood around the hospital. Another question. What is the impact of the urgent care walk-in centers opening all over? Are they located in lower income areas too? Are they a viable alternative method of care in these neighborhoods? Well, community health centers, especially in cities like Boston that have done a wonderful job of making them available throughout the city, are a terrific source of ambulatory care, primary care, dental care, nutrition, behavioral health, and other services. In Boston, they're often very well linked to specialty referrals and to admission to hospitals. In a large number of cities, though, care is often truncated at primary care, and it's very hard for community health centers to offer the full spectrum of care. Urgent care centers are sometimes located in low-income and African-American neighborhoods, but they tend not to be. They tend to be located in wealthier suburbs. The same for ambulatory surgery centers, which provide much of the care for surgery that's been emptied out of many hospitals. Those are located overwhelmingly in wealthier areas, and when they're not, their payer mix is heavily weighted toward non-public, non-Medicare, and non-Medicaid patients, toward privately insured patients, some Medicare patients, but very few Medicaid patients. So they tend not to serve the span of patients that hospitals with their emergency rooms, with their open door policies, serve. So the substitutes, the potential substitutes that we talk about are simply not there. Another fourth question. Historically, how do hospitals in Latino communities compare to those in African American communities and white communities in regard to hospital closings? Here we have a different pattern. In many cities until the 1980s, 1990s, 2000s, Latino communities were heavily concentrated in large cities in the West, Southwest, and roughly states in the arc from Texas to California. More recently, large Latino neighborhoods have arisen in the majority of cities. So far, Latino population mix is simply not associated with the pattern of closings found in African American neighborhoods. And it's hard even to speculate about the differences. In the cities with longer established Latino communities, density is lower, reliance on automobiles is much higher, reliance on public transportation is much less. There's often more room for hospital expansion if they wish in neighborhoods. And hospitals have not faced the same pattern of closings in Latino neighborhoods. But those are just early speculations about one possible reason. One thing we do find is that for-profit hospitals are much likelier to close in cities, and partly in response to, in association with racial factors, and partly owing to for-profit hospital owners' tendency to simply close up if they're not making money. Next question. You mentioned the idea of allowing the government to step in to stabilize needed hospitals. Is the government capable of doing any better than independently run hospitals? Sure. First of all, government is good at one thing in particular, which is spending money. Now, in the past, government has spent money in healthcare pretty much following a pattern, doing a very good job in expanding access by Medicaid coverage, Medicare coverage, new ACA coverage through the marketplaces, and Medicaid expansions. Government is very good at covering people. But in healthcare generally, the huge amounts we spend on healthcare, government money or private money, resembles heavily the pattern exhibited by the large herbivore vegetarian dinosaurs of dozens of hundreds of millions of years ago. Dinosaurs that consumed huge amount of vegetation, enormous creatures powered by walnut-sized brains that went around eating a lot and excreting huge amounts of what they ate randomly across the countryside. That kind of spending pattern for U.S. healthcare helps to explain how we can spend twice as much per person, 2.5 times as much per person, as the typical rich democracy. Fail to cover everyone, provide less care per person, and not live as long. waste in U.S. healthcare is enormous. But targeted spending by government that rests on identifying needed hospitals, that rests on setting fair payments to cover the cost of efficient delivery of needed care, can do a lot of good, because it's clear that we don't have a functioning market. We don't have anything like fairness or justice determining the survival of hospitals. And government can really level that and make sure that hospital deserts, like the deserts in Africa, stop growing. We need to stop both of those deserts from growing. And we need to reverse that trend where we can. Hospitals are vital. Healthcare is vital. Medical security is vital. We need to invest much more in prevention and in addressing social determinants. But failure to contain healthcare costs and healthcare's continued sponging up of every available dollar in the United States may be the single biggest barrier to adequate spending to address social determinants wholesale, the way they need to be addressed. We need a balance between prevention and care, because prevention always fails. Healthcare itself has never saved a single life. We can recognize that as a theological or philosophical question, not a medical question. And when prevention fails, medical security is vital. The United States spends enough to assure medical security for all citizens. And the persisting tragedy of failure to deliver medical security for everyone is a tragedy we have to overcome. And understanding the causes and consequences of urban hospital closings may help us to understand and maybe even help motivate us to attain genuine medical security for everyone. Thank you very much for joining me today.